Thank you so much for joining us today. My name is Inara, and today we are going to be talking about the psychological factors of pain during penetration. So I will go ahead and introduce our facilitators. First, we have Frances Field, who is a licensed marriage, family therapist in the states of New York, New Hampshire, Florida, and Maine. They are definitely someone who is very well versed in all things concerning vulvodynia, and definitely has extensive background working with this population, as well as Brooke Brownlee, an associate professional clinical counselor here at Modern Intimacy, who also has very extensive background working with clients in this population. I'm going to go ahead and let you two get started.
So I can start just an overview of pain during penetration. Some of these diagnoses may sound familiar to you, some of them may not. Definition of dyspareunia. So that's just the persistent or reoccurring pain during vaginal penetration. This can be lifelong, this can be acquired. It can happen before, during, or after sex. It's commonly underreported for many reasons, one of them being that there's this narrative that there is supposed to be pain during penetration, so it's often not sought out medically. Some people feel like it's dismissed often, so it is unfortunately underreported and understudied. Related conditions you'll also hear is vaginismus, so that's involuntary muscle contractions and spasms that prevent penetration. When the pelvic floor begins to tighten, it makes penetration really difficult or impossible. People describe it as a very sharp pain. Some people even describe it as almost like a knife. It can be so incredibly painful. Vulvodynia is more around pain that is centered around the opening of the vulva. So that's chronic pain. It can happen with just penetration, it can happen without penetration, and there's no identifiable causes with both vaginismus or vulvodynia. So the importance of multidisciplinary approach is, the collaboration between pelvic floor therapists, sex therapists, and other medical professionals is just providing wraparound care. Pain during penetration is really nuanced, so there's a lot of different layers. There's psychological, there's medical, there's also involving like the pelvic floor therapist to really help someone understand their body and when there's tightness and where there is discomfort and help them move through that. So really providing through like a therapeutic lens that's multidisciplinary is the best form of treatment when someone is experiencing pain during penetration. The biopsychosocial model, pain, it's not just physical, it influences psychological factors, social factors, biological factors, as were mentioned. This can really impact someone's view of self. It really impacts how they feel in their relationships, also just their disconnect or connection with their body. So treatment must be addressed as a whole person, not just the physical symptoms. As I was saying before, it really is a bigger treatment approach to really for someone to receive the best possible results because there are so many different layers to working with pain during penetration. Nara, you can do the next slide.
Sorry, I thought it was not muted. So some of the psychological components of pain, this kind of interplay between psychological and physical pain, right? So we have our psychological stress, which can cause that heightened, muscle tension, increase that pain perception. In people who are experiencing pelvic pain, there's a lot of psychological stress that often shows up somatically. So that's that increased pelvic floor tension, that's that clenching or guarding. Chronic stress can also make the nervous system a lot more sensitive. And then kind of everyday stressors can make flare-ups worse. So if someone is having a more difficult, even if it has nothing to do with the context of sex, that can also increase pain. And then we have our emotional factors. So that's fear, shame, depression, things along those lines. They can contribute to avoidance and kind of reinforce this pain cycle. So the avoidance can cause muscles to become tighter, more reactive over time, and it feeds into that cycle. And then there's that emotional burden that kind of adds an extra layer to the physical symptoms. So a lot of folks that we see who have pain during penetration also have overlapping diagnoses sometimes of depression and anxiety. And then we have those relationship dynamics, which can influence how pain is experienced and managed. So supportive partners can make a huge difference in treatment. If they validate the experience, they adapt intimacy, they're creative with intimacy, it reduces a lot of that emotional stress. But if partners are dismissive or impatient, or even if they're just avoidant, right? So maybe we're seeing them as supportive and they say, oh, we just won't have sex then, that can actually increase the pain that people are experiencing. So relational attunement is huge when it comes to treatment, kind of being able to know when maybe your partner's pain is showing up in different ways, even if they're not verbalizing it. And then we have societal stigma and misinformation, which can delayed treatment or misdiagnosis. So pelvic pain is often misunderstood and often is said to be in somebody's head, and that it's a normal part of being a woman, or simply stress related, which really leads to delayed care. And then there's just stigma around sexual and reproductive health as a whole, and that really discourages that like open dialogue with medical providers, clinicians, and partners. Right. Nara, if you want to go to the next. Oh, Brooke, I think you're on mute.
Thank you for that. Some intrapsychic factors that contribute to pain during penetration. The big one is shame and disgust. There's been quite a bit of research showing that individuals with pain during penetration have higher levels of disgust and shame around penetrative sex. And shame and embarrassment, it's often used as a defense mechanism, as a way of self-protection. There's also fear and anxiety. So the anticipation of pain, a lot of people report a lot of hypervigilance because they've had such intense pain during penetration. Any sort of intimate touch can lead to fear and hypervigilance and tightening of the pelvic floor, just in anticipation that any sort of physical intimacy might lead to penetration. So there's a lot of fear and anxiety around just intimacy in general, and just a lack of education of sex is so much more than just penetrative. It's such a broad spectrum. So perfectionism and control, anxiety related to performance or perceived failure. So this idea of, I've had pain before. What if I have pain again? What if my partner thinks if we're not having penetrative sex? What does that mean about me? Just a lot of fear and perfectionism around anxiety of experiencing that pain and that controlling and wanting to control that narrative. So again, with body image issues, discomfort with one's own body, shame and self-criticism, just kind of disassociating from their vulva, especially if they've had pain, feeling like their body has failed them in some way, that this is supposed to be pleasurable. They've heard that it's pleasurable and they're not experiencing pleasure. It comes with a lot of body image issues. Dissociation or disembodiment, feeling disconnected or unsafe in the body. Like if you're experiencing pain, can you trust your body? Can you trust your body to show up for you? Can you trust your body to feel pleasure, to feel connection, which are some common intrapsychic factors with people who experience pain during penetration.
So talking about a bit of the trauma and PTSD involvement, because I think when we think about pain during penetration, trauma can be a huge factor. It might not be a factor at all, but it is something to screen and consider. So sexual trauma, physical, emotional, relational trauma can also impact this. Sexual trauma can leave imprints emotionally on the body and in the pelvic region. Survivors may experience involuntary muscle guarding, so pain during intimacy or even medical exams. So when they're maybe getting their yearly pap smear, they're also having that tension and also a sense of disconnection from the pelvic area. And so even when trauma isn't necessarily consciously recalled, a lot of the time it's still present in the body. It's a reaction to it. And so I have folks come in a lot of the time and they can't remember a traumatic event. And then as we start to work somatically, some things come to the surface. And then there's also the non-sexual trauma, right? Then emotional neglect, childhood abuse, verbal abuse, religious or purity culture, medical trauma. And what that might look like is, chronic invalidation, living in fear. It oftentimes shapes how the nervous system responds at just like a baseline level. And experiences in purity culture might also create this internalized shame, fear of touch or distress in one's body. And it can really manifest in that pelvic tension in things like vaginismus. And then how fight, flight, freeze, and fawn may show up is that, fight might look like irritability or tension in the body. Flight might be avoidance of intimacy or any form of medical care. Freeze might be dissociation or numbness during sex or touch. Oftentimes, folks go from even pain to just numbness entirely because of that dissociation. And then fawn, which is that prioritizing of a partner's needs at the own expense of somebody's own comfort or consent. And then there's that hypervigilance. So it's that anticipation of the pain also causes that involuntary muscle tension. And so even when maybe the pain isn't present yet, just the idea that there's going to be pain creates that tension over time. And that pattern really becomes deeply embedded in the body. And that's probably one of the most difficult things to work out over time. All right.
Yeah, just kind of piggybacking off of what Frances was already mentioning and talking about is that fear avoidance model. This is something I share with my clients who are experiencing pain during penetration. I think it's a great visual of what might be happening in terms of their emotional response, physical response, and where, on a treatment perspective, where we try to interject. So the first kind of step and place we look is that fear of vulnerability. That causes emotional and physical withdrawal, like how you're talking to your partner, how your partner is responding. If they're not responding in a way that makes you feel safe, you're going to pull back physically and emotionally. Talking about these conversations is incredibly vulnerable, even if you're not partnered or you're dating or even with yourself at times with self-pleasure, having these conversations. If they're not going as is expected, it can cause that emotional and physical withdrawal, which leads to step 2, which is avoidance, leads to increased pelvic muscle tension and emotional disconnection. So again, we know that the body really keeps and stores our emotions. I always think of the body keeps the score. So the more kind of avoidance, the more emotional withdrawal, our bodies are shutting down, our pelvic floors might be tightening. That's why there's that hypervigilance, that emotional disconnection. That could, if you're partnered, leading to more conflict, which again is exacerbating these symptoms. And then if, penetration is tried to achieve, there's just that heightened tension, exacerbated pain, and that confirms the fear. So if I had penetrative sex, it's going to be painful. It is painful. And now I've confirmed that belief. And so that pain is reinforced, creating this perpetuating self-cycle of now I don't want to talk about it. I want to avoid it. That leads to increased hypervigilance in the body, which then your muscles are contracting, the pelvic floor is tightening, and then that leads to more pain. And it's just kind of a reoccurring cycle. So we want to, as clinicians, sort of interject and talk about normalizing the fear, normalizing what they're feeling, that it's not just in their head, that this is something they're experiencing in their body. Really doing a lot of psychoeducation, doing a lot of therapeutic building, allowing them to be emotional and to be vulnerable with us as clinicians is a huge step to kind of break that cycle. And then sort of confronting that pain. That could look like a pain journal of when are you experiencing this pain? Is it before you're having intimacy because of anticipation? Are you starting to notice what's happening in your body? You're starting to withdraw. So we start to do some of that mind-body connecting. And then ultimately, hopefully leading to recovery, whatever that might look like for that client. I think each time with whoever it is, it's different. Completing a recovery plan, looking if this does happen again, if I start to feel pain again, how can you readdress this? And so essentially that's what the fear avoidance model is speaking on.
So some interpersonal factors that impact pelvic pain is lack of sex education, skills or attunement. So a lot of adults enter relationships with really very little sex education. It is not comprehensive whatsoever. And this can lead to kind of this limited understanding of sexual functioning, what it should feel like, like conversation around it, emotional attunement. And without that understanding, oftentimes one partner's needs kind of dominate in the space. And then we have that relational conflict or the stress that also impacts the pain. So oftentimes I see clients who show up who have a history of infidelity or betrayal trauma, and they complain of pelvic pain or pain during penetration. And that can also be a defense mechanism in the body, right? That unresolved conflict, especially with betrayal or infidelity, kind of makes them want to push the other person away, or they don't feel safe enough to connect. And then communication deficits. So often, people feel very uncomfortable talking about sex, especially when sex isn't going right. So there is this difficulty in expressing desires, boundaries, emotional needs. And that kind of creates this cycle of maybe one partner feeling rejected because they don't understand that the other person is avoiding sex because it's painful, and that partner doesn't know how to share that. Disparities in pleasure equity. So one partner might consistently kind of experience more pleasure or satisfaction than the other. It's often tied to gender norms, especially in heterosexual relationships, kind of lacking the knowledge of the other person's needs, which can foster that resentment, disinterest over time. And then partner pressure or entitlement. Maybe one partner feels entitled to sex and the other one feels that they need to give it to them. So it becomes this transactional dynamic, which also decreases that emotional vulnerability and connection and really undermines consent and that authentic desire. Attachment styles are really important to bring into treatment. Your anxious, avoidant attachment might impact sexual and emotional intimacy because it kind of manifests in this way of either closeness or emotional withdrawal, and the body can respond to that. And kind of what we chatted about earlier about that relational trauma really impacting sexual closeness. Dismissive responses, blaming, shaming that partner response. So dismissing a partner's concerns or shaming them for their pain, right? It's kind of a tactic that kind of erodes that emotional safety and the sexual safety. And this can often lead to a lot of silence or mistrust or just emotional shutdown altogether. And then we have our sexual emotional labor, which is the other third shift. So one partner, typically a woman in a hetero relationship, takes on that kind of emotional burden of managing the sexual relationship. How often are we having sex? Is my partner pleased by the sex that we're having? They're very mindful of this and prioritizing typically the man's pleasure. Which includes initiating, managing the rejection, trying to make them feel better and kind of disregarding the pain that they're experiencing, and kind of becoming this emotional caretaker during sex.
So some collective and systemic factors are cultural norms and stigmas. Again, just in our Western society, kind of puritanative culture, there's some norms around, like I was saying earlier, that women's pleasure isn't like a priority. It could be painful and that's okay. You should speak out about that. A lot of stigma and isolation around pain during penetration and this idea that it's supposed to be pleasurable. People feel like they don't have a place to turn. Assumptions about pleasure and worthiness. If I'm not getting pleasure, am I worthy of getting pleasure? Can cause like this discrepancy, especially between couples. People growing up in religious trauma, purity culture, just high control religions, in groups, out groups, and othering. That also can cause people to have pain during penetration. Again, taught sex is not safe before marriage, and then you get married and now all of a sudden it's okay to have sex. That's a lot for the mind and the body to process. Sex negative sexual scripts. We have like a lot of this really negative scripts about women being the gatekeepers and men being the pursuers. And so as these sex negative scripts get passed on, how is someone internalizing those narratives, and how has that kind of shaped or formed their idea about sex and sexuality, like slut shaming, victim shaming? How has that played a part in their life or in their culture? Lastly, hopefully I'm pronouncing this right, is iatrogenic trauma and failures. So people coming in with medical, legal, therapeutic factors that have contributed to their trauma, feeling like they're not heard, having medical missed procedures, or having really painful births, feeling like they weren't cared for after, that can also lead to someone experiencing later pain during penetration.
So, pain in the context of sexism and misogyny. So, internalized shame about sexuality. So, that's the cultural messaging that a woman's sexuality is shameful. It can lead to discomfort, tension, and anxiety during sex, right? It's this feeling that a woman's sexuality should be hidden away and it is only made for a man. Fear of speaking up. Women might fear being dismissed or judged by voicing concerns about their pain, leading to prolonged suffering. Medical gaslighting, that kind of historical dismissal of women's pain by healthcare providers. It can kind of result in this untreated or misdiagnosed condition like dyspareunia. Cultural silence around female pleasure. So that's the lack of education, conversation around female pleasure, which kind of reinforces this idea that penetrative sex as the norm. They don't really talk about other ways to experience pleasure. And the belief is that penetrative sex is the only way to experience pleasure. And then feeling obligations in relationships. So kind of those traditional gender norms that might create a sense of duty to engage in sex, even when it's painful or wanted or unwanted. And also the obligation that kind of the man's pleasure comes first.
The second half of that, pressure to prioritize male pleasure. So these societal expectations may pressure women to engage in penetrative sex despite pain, leading to worsening their symptoms, feeling like they don't have a voice, and feeling like they're obligated because maybe they're in a relationship that they owe their partner this, which leads to, over time, worsening their symptoms and can cause other mental health concerns. So sexual trauma tied to the patriarchy, so high rates of sexual violence against women rooted in misogyny can lead to trauma-related pain during sex. Body objectification, so societal focus on female bodies as an object of desire can result in disconnection from one's own bodily autonomy, increasing discomfort and pain. Again, like there's no individuality if you're just focusing on someone as a use for your gain. This can cause a lot of great discomfort and pain within the individual. Decreased self-worth. So internalized misogyny can contribute to feelings of inadequacy or failure if one experiences pain, compounding emotional distress. Gender expectation of toughness. So women may feel they have to tough it out rather than seek help, again, prolonging the physical and emotional distress.
Do you want to go ahead and read the case example?
Sure, yeah. So for a case example, call her Grace, a 31-year-old female, heterosexual, Caucasian. She grew up in a Christian conservative household. Her parents divorced when she was 10 years old. Client reports that her mother was authoritative and told her she needed to wear conservative clothing. When the client didn't comply, the mother would say, "You look slutty and you're sending out the wrong message to people." The client reported that she got married to her husband 5 months ago. The client reported that she's always struggled with pain during penetration. Still, since getting married, the issue with her partner has only escalated. And now she reports he no longer initiates sex. Client reports that she has never been able to have penetration without pain, and she even feels a sense of dread engaging in any sexual contact with her partner. The client reports she has been to several different gynecologists who have found, quote, nothing wrong with her, and she has received a vaginismus diagnosis. She feels hopeless because she feels as though the pain is all in her head, and she would like to have a baby soon.
So we're going to look at this case example through a few different treatment approaches. Nara, if you want to go to that, perfect. So I'll let you take that away, Brooke, in that first half.
Yeah, so from a multidisciplinary approach, again, sending an individual like this to a gynecologist that they would trust and feel like they are a good fit, just to see on the medical end what is going on, getting hormones done, labs done, seeing and checking everything out there and what can be done medically. Sending them to a pelvic floor therapist to help them better understand where the tightness is. Is it around the vulva? Is it more deep into the pelvic muscle tissue? Introducing dilator therapy and also working with a clinician, sex therapist to help sort of do the psychoeducation piece and to help them get started on the emotional piece of their journey. So really doing that wraparound care. The intersectionality is just looking at what other diagnoses could be at play, understanding if there's maybe some anxiety involved, some depression, really getting a real good biopsychosocial of understanding what other mental health issues there could be underlying and how that would impact our treatment and approach. So for the biopsychosocial as well, just looking at, this client grew up in a conservative household, in a Christian home. What was the narrative around sex and intimacy? Was it ever spoken about at her house? What was the narrative she got at her church, within her community, and things like, you look slutty when you wear certain clothing. Like that's something as a clinician to note in the biopsychosocial of how does she feel comfortable in her own skin and what makes her feel comfortable. Again, getting married 5 months ago and understanding where she's at with her partner. It sounds like things have been escalated. So understanding their relationship background, what their kind of core values are, how they both engage in intimacy and what that looks like. And then again, it sounds like maybe this has been lifelong, understanding like how long these symptoms have been ongoing, as well as also putting in perspective, like there's that timeline of wanting a baby and understanding where she's at with that, doing a lot of education, a lot of understanding and building that therapeutic rapport. So for the trauma-informed care, like as clinicians, especially at Modern Intimacy, I feel like we all try to be trauma-informed, going at the pace of the client, really meeting the client exactly where they're at, not trying to push in essence, to re-traumatize them. So really meeting them where they are, really setting a framework to help them regulate, to help them ground themselves, because coming to therapy is emotional and vulnerable. So we want to make sure they have the tools and the skills to really self-soothe and to ground themselves. And so we want to really meet the client where they're at currently and in each phase of treatment.
So a bottom-up approach in this context, you can think about it literally as that, right? You're starting with the body, going to the cognitive. So a part of the bottom-up approach is really regulating the nervous system, building that body awareness before you dive into the cognitive processing. So an option here might be to build some grounding techniques, some breath work, some kind of gentle pelvic floor awareness, noticing, what does it feel like when you're in tension versus when you're in that space of relaxation. You might use somatic tools like body scans, certain movements, yoga. Trauma-informed yoga is a great intervention for this, which kind of just creates that sense of safety within the body. So someone like this in our case example might really benefit from this because she feels so much shame around her body and she's very disconnected. So then that kind of gradual exposure to kind of non-threatening touch. And we do this through what we call sensate focused therapy. So what that might look like, and I'll get more into it in terms of couples work, is kind of starting with her alone without her partner present and going through different forms of touch, really titrating the touch, right? From maybe the belly to the leg to the vulva, right? And just noticing when the tension begins and when you can kind of create maybe even some like breath work or some exercises around it to decrease it during touch. And then top down, this is also an approach that we can use. And that's really maybe working on some of those shame-based messages that she learned within that purity culture, right? What she wears created a lot of shame for her. And so that might be a part of it. So working through that, either maybe using narrative therapy or even some IFS, things along those lines. And then also just a lot of psychoeducation we're doing top down. We really want her to understand the reason for this to decrease the shame. I would say normalization, validation are the biggest things when it comes to decreasing shame in this work. And then for individual versus couples therapy, you can do both. Some people choose to do one or the other. Some people bring in their their partner into their individual work for a collateral session. But for this individual, for individual care, you might kind of start kind of like what Brooke was saying for the biopsychosocial. You want to understand the full personal history, all the traumas involved, right? So we already know there's relational trauma present. It sounds like with the relationship with her mom. It sounds like there might be some religious trauma present, and kind of looking around and seeing if there's any other forms of trauma that may have happened, and then really providing that understanding of the difference between maybe a little t trauma versus a big T trauma. A lot of folks like to disregard their trauma because they don't feel that it fits the narrative of what they were taught trauma is. And we really want to build that emotional regulation, that body awareness, and just help reduce that dissociation during intimacy and just in the day-to-day, and learning kind of pleasure techniques outside of just sexual intimacy. So we do this by pleasure tracking. So that might be, when you're washing the dishes, kind of just feeling the warm water over your hands, and being able to just have that mindfulness over different parts of your body. And so you're really laying that groundwork for healing and autonomy before bringing in those kind of relational dynamics. So for couples work, you really want to focus in on non-blaming communication. You also want to bring in a lot of psychoeducation. Psychoeducation is your best friend in this work, because so many folks just don't know what's happening. They have a lot of assumptions, but they just don't know. And then you want to bring in kind of like what I was saying before, that sensate work, right? Does this feel safe when your partner touches you in this way? And you want to work with, non-sexual touch, maybe a hug or holding of the face or a hand on hand. Does that feel too close, right? So you have lots of titration, helping the partner understand what vaginismus is for this client in this example, right? That it's not about them, that this is a story that maybe existed before them, and that there's, by withdrawing, they're also kind of unintentionally creating the cycle. And then we have something called the implicit model, which is fun to say. And what that stands for is permission, limited information, specific suggestions, and intensive therapy. So in this example, permission would really be about creating rapport with this client and creating a sense of safety, normalizing her experience, really focusing in on, normalizing the fear, the shame, the confusion. Limited information would be just really being very clear about educating her about what vaginismus is. What I've found sometimes is folks might come in with a diagnosis, and once they learn what vaginismus is, they say, I don't think I have vaginismus. I think it might be something else. And that actually even opens up a whole nother road or referral to another gynecologist or a pelvic PT to understand, is there, other things taking place for this person? Maybe this is vaginismus. I wonder also, if there's other pain involved, are we also working with vulvodynia? What's going on? And reassuring her that the pain is not in her head. All pain is real. Specific suggestions might be kind of introducing that kind of body-based intervention, certain breathing techniques, grounding, pelvic floor relaxation, just to kind of reduce that pressure and reconnect emotionally to herself. Intensive therapy, that's that deeper trauma work. It might be EMDR work. It might be doing some work on more so that relational trauma to, address the religious shame, early attachment wounds with her mother, or maybe the relationship with another caretaker. And we'd get that information through that biopsychosocial. And then we want to take a really collaborative approach, right? We want to suggest multidisciplinary team approach. We want to make sure they have a gynecologist that they trust, or a sex-informed professional, or a pelvic PT. We want to make sure that they have a team. That's the most important thing, because we can't do this on our own. And then we really want to focus in on that pacing and empowerment, right? Kind of what Brooke was saying. We want to make sure we're meeting the client where they're at. We don't want to push them to a place of complete discomfort. We want to take these little steps and also really acknowledge, I think the thing I say every day to clients is, we're not fixing you because nothing is broken. So that's something really to reiterate here throughout treatment. Right. Any questions? Lots of information. Oh, I think Inara, you're on mute.
I am on mute. Thank you so much. Yes, we wanted to open it up for questions. We do have some pre-submitted questions, but I just wanted to check and see if there was any questions that wanted to put in the chat. Why don't I go ahead and start us off with a question here. So from my understanding also in research, that it seems like there's a lot of underreporting for this type of pain. So what are what are some specific language or questions that providers can use to normalize having conversations with their patients about painful sex in clinical settings?
Do you want to take that one or do you want me to take that one?
That's a good question. I'm still processing. So if you have an immediate thought on your mind, please share.
I think one thing, and it sounds so obvious, but it's really important, is I find that the word even sex is something that folks are so scared to bring up. They feel really uncomfortable, but once you start talking about it and normalizing it, it just starts pouring out of them. So actually using certain language like intimacy or pleasure, or if you feel that it's appropriate, the word sex, I think that just opening the door allows for that and normalizing it, right? Especially as maybe a gynecologist, kind of having the ability to pause and say, it's really normal for some folks to come in and have this pain. Is that something you're experiencing? So already normalizing before the answer even happens so that they feel safe enough to bring it up.
Yeah, I mean, I would just piggyback, Francis, off of what you were saying, like allowing for that conversation to just unfold. Again, people who have pain during penetration, if they're going to a gynecologist, it often takes them so much to go to the gynecologist. It's already extremely traumatic for them to go. Just the different devices being used, there's a lot of fear there. So just normalizing, like if someone, or are you feeling discomfort? Is this discomfort like normal? Do you feel this often? Where else do you feel this? Just opening up that conversation, especially at a gynecologist office, because it takes, if someone's having pain during penetration, it takes a lot of courage for them to just even get themselves in the room. So being really gentle, really mindful, and listening. I think listening is a really big point too, of not just, this is just vaginismus and move on, but really just like allowing some space and time for someone to kind of unfold. Like Francis was saying.
That was great. Thank you. Can you, either of you, point to some signs or what would indicate that the need for a referral to a sex therapist in these situations when different providers are encountering people or in patients that have pain during penetration?
Yeah, I think a referral to a sex therapist, if someone is experiencing pain during penetration and it's not automatically ruled off that this is a medical issue, and even if it is a medical issue, I don't think talking about it in sex therapy is going to hurt. Like just talking about that experience with a therapist that's going to hold a safe space for you to just really open up about how your relationship with your body has changed or how that might feel for you in your relationship, in your own body. I mean, maybe I'm biased because I am a therapist, but I feel like you can't, if someone's experiencing pain, I think you can't really go wrong with a referral to someone who's going to hold a safe space, who knows about sex and intimacy and is comfortable holding space and giving psychoeducation about that.
Yeah. Well said, Brooke. I think we are very biased, but and so yeah, it can't hurt, right? It's something where you're literally, I mean, I see it as giving someone a gift to be able to share that experience in a place that feels safe to them. And a lot of folks are not talking about this with their partner, their friends, their relatives, certainly not, maybe, but it's really the only place that they feel they can. And I think there's probably a lot of medical providers who wish that they had more space to have those conversations with clients, and they just don't, right? And they're trying to attend to the physiological aspects of it, but they don't have the time. And so it's really a place where they can do that. So yeah, 100% agree with Brooke. I don't think it's ever the wrong move.
Thank you so much for that. Following up on that, especially with the limited time that clinicians have in their appointments, what can you share some best practices for providers to respond if a patient does disclose that they have had a history of sexual trauma or a pain during penetration?
I think that this is a really important question and kind of goes back to what we call trauma-informed care, which really every doctor, clinician, every single person there is out there should have some form of trauma-informed care and knowledge. So I think a part of this, right, is that if they're disclosing this, one, great, they trust you. That's a really great step, right? So they're coming to you and they're sharing this information. And so This is opening a door to have a conversation about what they need, which is really what you want to provide as someone who's in healthcare. We want to know what you need and how we can help you. Either that's through me or that's through somebody else, and I can give you a referral to them. But it's really being able to identify next steps and not allowing their vulnerability to fall on deaf ears and kind of disregard it as, oh, well, okay, you have trauma, it is what it is. So normalizing that, thanking them for sharing their experience, and then also how that informs also now your work with the client, right? So if they're disclosing trauma, you're not going to want to dive right into a vaginal exam. Now you have a lot of different context, right? Okay, well, what's going to create safety now? Do you need someone else in this space with us, right? We need to take our time. Are you okay doing this on the first exam? A lot of clients I say to them, go to a gynecologist 3 times and have a date with them, right? And then on that 4th time, they can take a look, right? So that's kind of the approach I would take.
Yeah, just to, everything you're saying, Frances, is so true. And also, they're like, you might feel some of these questions are out of your scope of practice. And you're like, well, I don't know what to do with this piece that feels that it's not my place or not my scope of knowledge that I feel comfortable sharing. And that's when like that honesty of, I hear you and like, thank you so much for your vulnerability. And let me like help you, put you in the right direction. Like, here are some options for you. Maybe a therapist would be a good fit for you. How does that feel? Maybe talking to a therapist. Because I think, we don't know everything about everything. And sometimes it just feels like out of your scope of practice, out of your competency. And that's totally okay to give a referral in an area you think would be a place to like speak more to that.
Thank you for answering. So I'm going to plug in here that Modern Intimacy is actually starting a virtual group therapy process group for people who experience pain during penetration and have pelvic pain. Brooke and Frances, can you speak a little bit more about that and what folks who are working with patients who are experiencing this, who might be a good fit for referral for this kind of group?
Yeah, well, first of all, I'm very excited. Brooke and I teaming up for something that we love to talk about, as this presentation showed. So so it's going to be a very small group, about 8 folks or so, I think. And it will be a weekly group. So we're going to meet about 2 hours, and it will be a process group. So they will get some skills and some understanding and some psychoeducation, but it's also a place to create community, which is the thing that's missing the most, I would say, when it comes to these treatment plans. And that's across the board. That's for medical doctors, but that's also us as clinicians, right? When I have someone come in with pain during penetration, I don't think I found one group that I can refer them to, and they feel so isolated. And like we said throughout the presentation, the number one thing that really helps them is normalization. So having that community is really essential in the healing process. So in terms of when to know to refer, kind of piggybacking on what we said, I mean, if they're having pain during penetration, this would be a great group for them. I don't think that there's really anything that could hurt them in this group. I think it would just help them. We will do a 1-hour intake kind of assessment, just to see if they have any questions, but also to assess if there's any kind of other overarching concerns that are happening that might not make them a great fit for this group. But that's kind of the process that we're going through right now. I don't know if there's anything, Brooke, do you want to add to it?
Yeah, I believe it's 12 sessions or 12 process groups total. And I think the time and the duration is hopefully to build a community. I can't tell you how many times I've worked with people who have pain during penetration. They go, do you have a group? I don't have anyone to talk. I can't talk to my friends about this. I don't know who to talk. I would love to hear from other people who experience this. I feel so alone. I'm super excited about this group, and I'm really hoping that the people that come can really join and get an understanding and not feel so isolated. I'm really excited to be a part of this group. And I think if you're working with anybody who's mentioned that they've had pain during penetration, if it's lifelong or if it's acquired or if it's recent, I think all of that sort of can be a part of this group. There's a space for anyone who's experienced pain during penetration.
And to add, I think the age ranges, right, Anara? Do we have those? I think it's from 25 to 45. Is that what we have on there?
I believe it was just over 18.
Over 18.
Yeah. So we are getting close to time here, so I wanted to start wrapping up, but I wanted to just make room if there were any other questions, and if not, then here is how, oh, that's the wrong way. Is how you can stay in touch with us. I'm realizing I didn't really introduce Modern Intimacy as a whole at the beginning, but Modern Intimacy is a sex and relationship therapy practice. We offer trauma-informed personalized care to individuals and partners navigating challenges with mental health, intimacy, and relationship structures of all kinds. We have a really deep focus on embodiment and capacity building, and have, as you can see, a diverse team of experts that provide a judgment-free space for healing and really that safety for exploration. So this is how you can stay in touch with us. Please feel free to reach out to me personally. My name is Inara again. I'm the Modern Intimacy's Marketing Communications Coordinator. So we would love to get in touch with you around just different referrals and how we can work with you as different providers and your offices on getting your patients the overall wrap around treatment and best care as possible. We are on all major social media platforms, including LinkedIn, TikTok, Instagram, and YouTube. And we have a bi-weekly newsletter that goes out to our general list, but we are also revamping our monthly provider newsletter. So with that, I just want to thank you both again for taking the time today and sharing with us a little bit more about pain during penetration and how we can help. So yeah, you will have a great rest of your day. Thank you so much.
Thank you. Bye.